Good day. We're going to review the actions after return of spontaneous circulation following a cardiac arrest, and specifically concentrating on the management of the post-cardiac arrest syndrome. Once again, you need to review all the literature involving post-cardiac arrest syndrome and ROSC. This is not a comprehensive lecture. It's not going to teach you everything. You also need to be familiar with the anatomy, the physiology, and the pathology surrounding cardiac arrest, as well as review the resuscitation literature. So we have a cardiac arrest. This is followed by a resuscitation by the paramedic. During cardiac arrest, we essentially have a state of global ischemia present in the body. There's only a low flow state or a no flow state in many or all of the tissues. And this will bring about anaerobic respiration and the production of waste products, as well as certain actions on the cells, which result in potentially damage to the cell membranes or rupture of the cells. At return of spontaneous circulation, we have sudden reperfusion of these previously underperfused tissues. And these produce effects at two levels. Firstly, they produce cellular and biochemical effects, and then they also produce certain organ responses. Let's have a look at the cellular and biochemical effects. These are brought about by deranged mitochondria, oxygen-free radical formation, programmed cell death or apoptosis. There's quite a strong immune response involving cytokines, tissue necrosis factor, and interleukins. There's a neutral and platelet activation, and the platelet activation might result in clotting, specifically clotting and sludging in the microvasculature. At the organ level, we have myocardial dysfunction, or myocardial stunning as it is currently known. This might result initially, at least, in a hypodynamic response. Remember, typically they'll have quite a lot of adrenaline, intravenous adrenaline on board. And this might also be followed later on by a hypodynamic response. Typically, you get transcapillary leak. Remember, the blood capillaries are not functioning as they should, and this results in a lot of the intravascular fluid moving into the extravascular space, resulting in firstly hypotension. And this hypertension needs to be read together with the myocardial dysfunction, but we might also then get swelling of the tissues. There's also a loss of vasoregulation, in that the autoregulatory responses do not occur as they should. And frequently we find an adrenal insufficiency, meaning the body does not cope with the post-traumatic stress as well as it should. In the central nervous system, the reactive oxygen feces have effects on the brain. There's cell damage together with apoptosis, specifically in the central nervous system. The endothelial damage as well that occurs in the blood vessels might result in disruption of the blood-brain barrier. There's impaired autoregulation and formation of cerebral edema as previously described. Overall, the patient will be suffering from volume depletion, loss of vasoregulation, and be in a prothrombotic state. And don't forget the myocardial dysfunction. And once you've achieved ROSC, you might still have whatever caused the cardiac arrest. That pathology has not necessarily gone away, unless, of course, you were dealing with cardiac arrest from a closed airway and you were able to open that airway. You might have addressed the cause then, but do not forget that you still need to go on and either search for the cause or manage the precipitating pathology. In terms of management, well, it's basically at the pre-hospital care level, together with managing the precipitating pathology as best possible. The management of the reperfusion syndrome especially is aimed at optimizing oxygenation and ventilation, as well as optimizing the hemodynamics of the patient. In terms of optimizing hemodynamics, and this might be the first thing you want to do. You might not have had a chance yet to put in an advanced airway, and now once you've achieved spontaneous circulation and the patient's heart is beating, before you could go ahead and produce or provide an advanced airway per the regular RSI procedure or the regular airway management procedure, you do need to optimize the patient. So it might be a good idea to start with optimizing the hemodynamics, and you do this by restoring the intravascular volume. through small crystalloid boluses, 250 to 500 mils at a time. If this is ineffective, or if the pathology is, such as in sepsis, is of a type where you need to constrict the peripheral vasculature, you can add vasopressors to this, adrenaline at 0.1 to 0.5 microgram per kilogram per minute. The MAP targets you're going for are the regular, the normal MAP targets of 65 millimeters of mercury. And if you're dealing with a traumatic brain injury or traumatic spinal cord injury, at 85 millimeters of mercury MAP to combat the potential for raised pressure within that system. If later on, if you're looking for a pure inotrope, something that affects the heart only and it's not a vasopressor, you can go with dobutamine at 5 to 10 micrograms per kilogram per minute. Just one more thing I want to say on this is that myocardial dysfunction is seen in most patients, in the majority of it, and it definitely contributes to increased morbidity and mortality. Myocardial dysfunction occurs within the first 8 hours following ROAC, so you might still drop the patient off at hospital in the hyperdynamic state. However, if they start to deteriorate, you do not be alarmed. It is part of the normal response to reperfusion, and you manage it as described on the slide. The actual cardial dysfunction itself might result from a direct injury of the myocardium. It might result from compressions and defibrillation that was done during the CPR. Surge of catecholamines, there might be a depletion of ATP stores, which then need to be built up, as well as the generation of oxygen-free radicals. In terms of oxygenation, well, for a start, it goes without saying, is you maintain an airway, and you maintain that airway in the most appropriate way possible at the time, including an advanced airway if that is needed. In terms of positioning, remember we might be dealing with formation of cerebral edema, so position the patient's 30-degree head up, and this also helps to protect against regurgitation. Your target is normoxia. You are not looking for 100%, you're looking for something around 94% on the saturation. And just be aware though that your actual quality of your saturation reading is dependent on the quality of the peripheral perfusion. If there's very poor peripheral perfusion through the fingers or the earlobe or wherever it is you placed your SATS probe, you might get a poor reading or a low quality reading. Pulmonary dysfunction is quite common after cardiac arrest, and this typically results in a hydrostatic pulmonary edema resulting from left ventricular dysfunction. You might have a non-cardiogenic pulmonary edema to deal with, which results from either inflammatory or infective processes or physical injuries, depending on what pathology. There might be atelectasis. You might have to deal with aspiration. Remember, there's probably going to have been a period of bag valve mask ventilation prior to your advanced airway, and that might have filled the stomach and resulted in aspiration as well. And typically patients develop a regional area of VQ mismatch, which might decrease arterial oxygen content. So, and just remember then, of course, is that your oxygenation is also dependent on your cardiac output. If your cardiac output is not sufficient, you're not going to get adequate oxygenation simply because you don't have adequate blood flow through those lungs. In terms of ventilation, what are we looking for? Well, typically we want to maintain normocarbia as best as possible, and we're looking to stay in the range of 35 to 40 millimeters of mercury on the end-tidal CO2. In terms of if you're using a ventilator, and I think it might be a good idea to use a ventilator over here. The patient's been through quite a stressful event. Their body needs to rest. The respiratory muscles need to rest. So at least in the pre-hospital phase, in the short term, it's probably a good idea, especially if you have a advanced airway in place, is to keep that patient flat or keep them paralyzed. Remember, just bear in mind that if you're using sedation, you need to take into account the effects of the drugs on the stunned heart. So is probably to keep the patient paralyzed, and you use just a controlled mode of ventilation. Because of the potential for inflammation or pulmonary edema, use a lung protective strategy. So starting at 6 mils per kilogram and working up to 8 mils per kilogram tidal volume. Please bear in mind that this is lean body weight, so you need to calculate this based on the patient's height, especially with the obese or very overweight patients. Do not go on total body weight. You're going to expand those lungs too much. You set your FiO2 just to maintain saturation of 94%. And you set your respiratory rate once again within normal ranges just to maintain SATs and end-tidal CO2. Don't hyperventilate the patient. In terms of PEEP, yes, the patient does require PEEP, even though it might add a little bit of extra strain to that right ventricle, but you do want to maintain lung compliance, and one of the best ways to do this is to prevent atelectasis, and that also then improves oxygenation. In terms of supportive care, remember with this massive reperfusion, we might see all sorts of arrhythmias forming. Remember, there's a lot of electrolytes, specifically potassium and other intracellular electrolytes, which are not normally in the circulation, which might not have come out of ruptured cells and are now having to work their way through the heart and have their influence on the conduction system. So you might have to deal with arrhythmias. There's no reason to provide prophylaxis just because. You treat and manage the arrhythmias as they arise. In terms of glucose, we do not looking for a hypoglycemic state. We want to maintain normoglycemia. And if the patient is originally hypoglycemic, or if hypoglycemia was part of the reason for the cardiac arrest, then of course you provide glucose per normal. In terms of temperature, very important is to avoid hyperthermia. So to do this, just apply surface cooling techniques, and if necessary, provide antipyretics. Typically, you might want to use paracetamol. Just please be aware of contraindications to paracetamol. Seizures, once again, you treat the seizures as you would normally, typically for status epilepticus in the pre-hospital environment. In terms of targeted temperature management, previously known as therapeutic hypothermia, this is not something that you are going to undertake in the pre-hospital environment. We're not going to initiate it in the ambulance. The slide is just here included because you might find yourself transferring such a patient. But to help with this along is that previously in trauma, we spoke about, especially in trauma, we spoke about administering warm fluid boluses. So here in cardiac arrest, you don't necessarily need to administer warm fluid boluses. They will undertake the TTM in hospital, meaning they're going to cool the patient to a degree of mild hypothermia, 33 to 35 degrees C. It's not a pre-hospital procedure, but you don't specifically need to keep the patient warm in the way you would other patients. So just specifically be aware of hyperthermia. If you are going to give fluids, they can be cool. In hospital, they might use fluid as cool as 4 degrees C. It's unlikely you're going to get it that cool, but you can administer fluids that have been cooled or at least haven't been warmed to the patient when you do the fluid boluses. Thank you very much.